do you have this week?
I have a question about when we're treating like something like say knee osteoarthritis, like our kind of hierarchy of therapy is like Prolo is like relatively speaking the weakest, and PRP is like the next strongest step, and then stem cells is like the big guns.
Yep.
How much better and how much longer lasting do you find PRP is than Prolo? I asked because we had the regenerative medicine class yesterday, and I did a study where they were comparing PRP and Prolo. It was a pretty basic study, but they had like a 2-month checkpoint after doing 2 injections, and then a 6-month checkpoint. And they kind of missed like the inflection point of where they stopped improving, and then the symptoms started to get worse again. So it made them look similar, just that the WOMAC scores were better with the PRP group, and that was really kind of the only difference. I was wondering if you could.
So there isn't any really good studies, just kind of like that study, because it's hard to track when does that change happen, when does it fall off. Generally what I see in clinical practice is the results from prolotherapy usually tap out at the 6-week mark, if not earlier. And some patients it's a little bit longer, 8 weeks. Other patients it's a little bit shorter, around 3 to 4 weeks. But generally, they get the bulk of their healing from that treatment in about 6 weeks. With PRP, that's usually longer. It's usually anywhere from 2 to 3 months. And again, some patients might be a little bit longer, but generally it's about 8 to 12 weeks that this healing happens. I think there's a little bit of difference in the rate of healing, but I think once you're after kind of like the first week or two, the rate of healing between the two is the same. I just think that there's a stronger signal to the body for that healing to last longer. And the reason I think the initial first week or two is different is because we generally see a stronger pro-inflammatory effect with dextrose Prolo than we do with PRP, at least the way I do PRP. So I don't get, my patients on Prolo are more likely to have kind of that 3 to 5 day flare, whereas with PRP, it's not as much. Yeah, they're sore, but it just doesn't seem to be kind of as extreme as the Prolo. And so, if it's like Prolo they get worse and PRP gets a little worse, but then I feel like kind of at that 1 to 2 week mark, the rates of healing are the same. Maybe a little bit better for PRP, but I think what just happens is the Prolo levels out, but the PRP healing is still occurring. And I kind of think the same with stem cells. Now, I'll layer this in and caveat this, that we have to remove the anti-inflammatory aspect. But in terms of the actual tissue healing, I don't think stem cells actually heals tissue faster than PRP, or that PRP heals tissues faster than Prolo, because the actual healing is not technically happening from what we inject. It's from the body initiating that healing response, and we all heal at roughly the same rate when you have like characteristics between people. Now, PRP tends to have a stronger anti-inflammatory effect compared to Prolo, and then stem cells have an even stronger anti-inflammatory effect. And so what it will generally look like is if someone has a lot of inflammation, if we do a PRP versus stem, I expect them to get a stronger anti-inflammatory effect for the first kind of like 2 to 3 weeks compared to PRP. So that makes it seem like they're healing faster because because of the stem cells versus the PRP. But I think it's just the fact that there are stronger signals within stem cells versus PRP, and then PRP versus Prolo for actually reducing inflammation that's associated with knee osteoarthritis. Does that kind of make sense?
Yeah,
okay.
Absolutely.
Do you have any good resources for us, like books I know this is a new and emerging field, but something that just really lays things out. And I know everybody has their own different ways of doing things and timelines and solutions.
What specifically, because there isn't a single good source.
Okay.
But what do you feel that you want to learn more about, so I can try and pick my brain on which aspect? Like, is it the science behind prolotherapy?
That would be good.
Okay, so Tom Raven has a textbook on prolotherapy, which I actually think might be at the school's library. I could be wrong on that, but that is a good resource for understanding kind of how prolotherapy works, at least at the time it was written.
And then like maybe a book that has injection sites for each joint, different avenues, ways to go in.
Baumgartner has a book, which we have an old version here. I can show you. This is for palpation guided, so it goes over the landmarks for all the major joints, where you would insert, kind of where you'd redirect, that type of stuff. That I think is good, and I learned a lot from that book. Outside of his, I'm slowly putting one together, just because I do things differently than he does. But outside of that, I don't think there's really any good text showing locations for injections.
Did this book show that? Do you remember this one from last quarter?
Yeah, so that one shows how to do nerve injections.
Oh.
So that's going to be more so for here's patient positioning, needle entrance, what landmarks you're looking for like a brachial plexus block, which a brachial plexus block is identical to a brachial plexus nerve hydrodissection. It just depends on the solution that you're using, right? An anesthesiologist is going to use ropivacaine for surgery, or we're going to use something like D5W or PRP or stem cells. So that one's more for nerve hydrodissection, but it's still a good book to get. I'm trying to think. The kind of gold standard book for ultrasound guided injections is Malanga's book, Malanga. It is, so Malanga does, he's an MD, and he does a lot of orthobiologics, but this textbook was written from a, I'll say like a steroid type approach, meaning you're not going to find a lot of, here's how to inject. Like, he has MCL, and I'm pretty sure he has LCL, but then there's nothing on like coronary ligament. Like, so some of the smaller structures that don't generally get addressed with a steroid approach aren't in there. But it shows you patient positioning, needle selection, and all that kind of stuff for ultrasound guidance. And then for fluoroscopy, the interventional spine, the International Society for, the acronym is ISIS. Well, it used to be ISIS. They dropped the first I, and now they're just CIS.
It's a good idea.
I
Spine
remember
Intervention
that.
Society. That's it.
Maybe Dr. Nick's class. I can't remember. Somebody's class. I remember that. I'm like, what?
About the ISIS book.
Yeah.
Bethel's probably mentioned it.
Okay.
Because he still calls them ISIS. But that's the gold standard textbook for fluoroscopy guided approaches. But that's, again, a pure, like, spinal joint injection.
Any suggestions for reading x-rays?
No, what I would do is I would, you can sometimes find the reading lists for different med schools. I've actually found a few different residency handbooks from med schools. You just type in like Stanford Resident Ortho Residency Handbook PDF, and sometimes you can find it. So what I did, because I just got a new anesthesiology textbook, is you can search for like the reading list or the course reading list or whatever for different programs. So you can look for a radiology program and see if you can find their reading list on what textbook they recommend for x-rays or MRIs, and then you can get that.
Okay, cool.
Dr. Nelson, did you know your flashlight's on?
No. Thank you. From time to time.
Any other? Okay. Also, YouTube has a lot of really good resources on how to read imaging.
YouTube?
Yep.
Regarding fractures, like I was just looking at Dr. Grice, and she had a trimalleolar fracture, which they had to address through, rods and different pins. How can we support healing in those cases? Would it be before, after surgery, and is there contraindications, while the, say, pins or surgical kind of like appliances are in place?
So, the general approach that I take for those patients is I get them into surgery, because that's the first thing that they need to do, right? I had a patient who had a comminuted fracture of the first metacarpal, and so it was basically like it kind of shattered and one of the pieces actually broke off. And he called me and he's like, "Hey, can you inject this?" And I look at the x-ray, I'm like, "No, dude, you're going for surgery. Here's who I recommend. Go to surgery, and then I'll help you afterwards if you still have issues." So we went and he got it surgically put back in, and then I watch and wait. So because there's multiple theoretical avenues that could happen, right? He could have a patient could have a full resolution and they have no pain, and it's almost like it never happened. Maybe there's usually, when you have to put rods and screws in, usually there ends up being some range of motion limitations, but a lot of the time it's for the patients in this hypothetical category, it's no big deal. That's one. The other one is that it helps with their pain and like what happened, but then they've got lingering pain afterwards that's different than what they had before. If that's the case, then I'll go in with either Prolo, PRP, stem, or perineural, depending on what I think is going on, in order to actually address that. And then the other avenue is the surgery made them worse, right? And then I go down the whole of, okay, well, did they damage something when they were doing surgery? Usually it's a nerve, and then we approach it like that. So I still wait for, just like after an acute injury, I don't want to just hop in and treat with really much at all for the first at least 4 to 6 weeks. Same thing after surgery. I let them kind of, ride that wave of healing from surgery until they're stable. It's not swollen, the post-surgical pain's gone, all that kind of stuff before intervening with any therapeutics. Yeah.
Makes sense. And then what about, say, in the long run, 2 months after surgery, maybe they still have some pain in the area, and we talked about scar tissue therapy, but say like they don't have too prominent of a scar, keloid, or anything like that, but do you see issues with maybe deeper scar tissue
Usually it's just nerves.
It's nerves.
Yep. Usually it's nerves that have been pissed off from the surgery, whether they got moved and that irritated and agitated them, or during the healing process when there's some swelling, they got occluded and compressed for too long, and so now they're in a vicious cycle of neurogenic inflammation, or they were deprived of oxygen, or they were deprived of nutrients because of that healing response from surgery. So most post-surgical pain patients have some component of neurogenic inflammation.
That makes sense.
Yeah. Any other questions before we get into the hip?
I got like 6.
Okay, go.
PRF, I guess we can start there. Since we talked a little bit about it this weekend, have you dug into any of the
I haven't
information yet?
Not a lot.
Okay.
What is that?
It's a platelet-rich fibrin clot. So you basically you're making the clot with the platelets and then injecting the clot. Apparently you get a lot more growth factors, but there's limitations because you have I think it's 30 or 60 seconds from when you make the clot to inject. So
Wow.
it's a little difficult logistically on that when you're using imaging.
What size needle do you use to inject it?
I think you can get away with a 22 gauge needle.
It's just a difference in the concentration of which you're spinning, or is it a different portion of the serum
You don't use any anticoagulants.
Okay. So you're
So
spinning
not
without
putting-
an
you're not-
anticoagulant.
Yeah, you're spinning it without anything in it.
Okay.
Yeah,
Yeah, I heard the concentration was a lot higher, of growth factors.
of growth factors. Yeah.
Yeah.
Is that what they use in the disc seal procedure to seal up the?
No, that's an actual fibrin plug, so that's a little bit different. So that's a reconstituted fibrin product. It's not a PRF. No.
Have you thought into any of the indications for hydrodissecting arteries yet?
Many. We're gonna start playing around with it here.
Oh, really?
Yeah.
Can you think of a rationale as to why? Is it simply blood flow, or is it more of like a arteriosclerosis, or why would you hydrodissect an
I
artery?
think my suspicion is it's a neurogenic inflammation because there's still C fibers that line arteries, and so if you have C fibers that are lining arteries, those can become painful.
I don't know, C fibers. So you can have sensory of the soft or the smooth muscle around the artery.
Mm-hmm.
Interesting.
Mm-hmm.
Don't a lot of arteries run in the same pathway as nerves?
Yep.
So they're right around each other anyway.
Yeah.
So would you hydrodissect them from each other, or just hydrodissect them as a bundle?
Well, so in some areas, the nerve is in its own fascial sheath compared to the artery. In other ones, they're together. Like when you do a nerve hydrodissection in the adductor canal, you're getting the artery at the same time.
Right.
And where if you're doing, for example,
Like a wrist.
yeah, like at the wrist, they're separate.
Right.
They're close in proximity. They're
Just
running
different
together,
planes.
but slightly different fascial casings.
Interesting.
Mm-hmm.
I guess just one last one since we were talking about arteries, legit like a procedural kind of question. So we generally always aspirate, when we're doing our maybe perineural, make sure we're not in a artery or vein. If we do ever aspirate and we get blood, and we redirect, of course, is there any other steps or concerns we need to have?
No, you just apply pressure afterwards because you nicked a blood vessel, so you could stop a hematoma complication. Just apply some pressure.
Yeah, probably clot, but it
Yep.
usually self-resolves.
Yeah. Yeah.
Okay.
Is there a way to, let's say you aspirated and you got some blood, is there a way to tell, other than, I guess, looking at the color of the blood, whether you're in an artery or a vein?
No.
No way.
Not unless you're under ultrasound and you then compressed and you locked it. No.
But perineural, we're not even that worried about because there's no anesthetic in it.
Right.
So even if you're right.
Yeah, the only downside to being in a vessel when you do it is you just didn't get the therapeutic effect in that area.
You lost your solution.
You lost your solution.
Yeah. But now with Prolo, with the small amount of ropivacaine we're using, is there any concern?
If you're above the belly button, yes.
Because then it can make it to the heart.
No.
No? Brain?
Then what happens?
Probably gonna have syncope. It's gonna hyperpolarize the brain. We kind of need the brain for all our functions.
Okay.
You could be fatal.
How could it be fatal?
If it affects the brainstem, and it affects breathing, or it affects the centers for a lot of rhythmicity of the heart. Is that?
Okay. So it does all that, but why does the heart not stop?
Oh, it's got its own That's not a fun pacemaker
Yeah.
cells.
So if you ever get an anesthetic centrally, what will happen is the patient will have a seizure. You just may not see it because it might happen so fast that they actually go into respiratory arrest and basically almost like a coma of the brain because you just numbed the brain with anesthetic. They'll stop breathing because you have completely shut down the respiratory drive centers. The heart will kick in its automatic pacemaker, so it'll drop. It'll be at about 40 beats per minute. But then your job is to
Provide probably respirations.
Yep. So you're on a bag valve mask with oxygen to keep them stable and not let them go hypoxic until they wake back up. It's usually about 10 minutes.
Is there antidotes for that? Is adrenaline or
No. Oh,
let's keep it out of the artery then.
Well, the antidote you'd have to re-inject in the central nervous system, which you probably don't want to do, right?
Right.
You don't want to place more problems or drugs in the central nervous system.
Yeah.
I actually think you can do what's called a lipid rescue, but I just don't know much about that. So I've heard people talk about having lipids on board for stuff like if you're doing stuff in the neck. But okay.
So I use guidance. If we're in the neck.
Well, that's why you use guidance. That's why you get proper training. It's why you make sure you have oxygen in your clinic if you're going to do any injections. It's a huge pet peeve when I see docs don't even have an oxygen tank in their clinic and they're doing Prolo. Even if they're not doing spine, if you're doing shoulder, all of a sudden your patient stops breathing. What are you gonna do?
But in
Mouth
that
to
case,
mouth for 10 minutes?
so so oxygen will help, but we would still need a bag for them. Right?
Yes. Yeah. You have to force in air to expand the lungs. Yeah.